So I am going to go ahead and welcome everyone to the 2020 Public Health Law Virtual Summit. We have two presentations in this session, and each presentation will be followed by a Q&A. Use the chat feature to submit your question. If you encounter technical difficulties, go to the navigation and select the help button. Now I will turn it over to our first speaker, Nicole.
Hi, everyone. This is Nicole Huberfeld coming to you from Boston University. I'm pleased to join you today with Sydney Watson, and we are going to be speaking about Medicaid's vital role in addressing the health and economic emergencies created by COVID-19. This is going to be structured a little bit differently than anticipated because, unfortunately, our dear friend Elizabeth Weeks was unable to join us today at the last minute. She's taken on some new associate provost responsibilities at the University of Georgia. So Sydney and I are going to cover her chapter for her. Luckily, Elizabeth and I have worked together for a long time as co-authors, so I feel I can deliver her content pretty well, and I know that Sydney can too. So thank you for bearing with us and allowing us to step in. So I'd like to begin today by talking about how Medicaid's safety net is vital, absolutely crucial, to helping states respond to the crisis that is COVID-19 and frankly respond to any national emergency. Medicaid is a cooperative federal state program, as many people are aware, and Medicaid offers states quite a lot of flexibility, which means that in some instances that allows states to be ahead of the curve. When we look at states like Massachusetts, which created universal health insurance coverage before the rest of the nation, that was done largely with a giant Medicaid waiver. On the other hand, Medicaid's flexibility allows for variability. And that variability leads to variable coverage and benefits, which exacerbate existing disparities in coverage, access to care, and health outcomes. These things contribute to the fact that in the United States, health is very much tied to zip code. So even though we'll largely be talking about the role that states play in considering Medicaid's role in COVID-19, I want to be clear that it's more than just a state matter. This is also a local matter because we have variance by zip code, and even within a city, as we heard from our plenary speakers this morning, the Bronx is different from Manhattan. Medicaid is a vital tool for the COVID double disaster that is an economic and health disaster. And so for that reason, we also want to explain why non-expansion states are missing a key tool in their toolbox. To help you understand everything about Medicaid and COVID, I want to start by working through some of the Medicaid basics, and then I'll turn it over to Sydney, who will talk about some of the emergency methods that Medicaid has engaged over the last several months. Medicaid is designed to help low-income people. The program has specific protections that make it so that it addresses the specific needs of people who are poor. The federal state structure of Medicaid makes it so that people who live in any state, to some degree, get the same benefits, coverage, eligibility rules, and other features of Medicaid because federal law sets certain requirements that make it so that those rules are the same nationwide. These rules are key to ensuring that Medicaid can secure coverage and care for the people who are enrolled in the program. States must abide by federal law in order to receive federal funding for Medicaid. And as many of you may be aware, Medicaid is often the second largest budget item for most states. So in a time like this, where states are losing tax dollars and starting to face budget crises, the federal funding that's available through Medicaid becomes even more important. So what are the core features of Medicaid that make it so that Medicaid can protect and serve low-income populations? Well, first, states must abide by federal law to get federal money. In order to prove to the federal government that they are abiding by federal law, usually states submit what's called a state plan amendment. The state plan amendment expresses both how a state is abiding by federal law and how the state will work through available flexibilities in Medicaid. And those flexibilities are important too, because those flexibilities make it so that states can make choices within Medicaid. Some of those choices are key to responding to a crisis. So state plan amendments are the #1 way that states describe how they're working with the federal government and Medicaid. But we also have something called waivers. Section 1115 waivers are the most predominant form of waiver, but we also have 1915 waivers for home and community-based services. 1115 waivers allow states to explain to the federal government how they will not comply with the Medicaid Act, but rather try to do something different or better that serves the purposes of the Medicaid Act. So 1115 waivers are also key to our conversation today. Within federal law, there are key features of Medicaid, such as unique eligibility rules, comprehensive coverage and benefits, limited out-of-pocket payments, and due process and other safeguards. So let me talk about each of these for just a moment. The unique eligibility rules in Medicaid are both substantive and procedural. Historically, Medicaid only covered people who were deemed deserving: children, parents, people with disabilities, the elderly. The Affordable Care Act made it so that childless adults who were earning up to 138% of the federal poverty level were also eligible for Medicaid, making Medicaid's safety net much more complete nationwide. However, as many of you probably remember, the Supreme Court in National Federation of Independent Businesses versus Sebelius decided that mandatory Medicaid expansion was unconstitutionally coercive. And so with that, the Supreme Court decided that the Medicaid expansion was voluntary. The Medicaid expansion became voluntary, allowing states to opt out of Medicaid expansion. And so I'm just going to briefly share my screen to show you what the state of the nation is right now. At this moment, we now have 12 states that are still voluntarily not choosing to expand Medicaid eligibility. What that means is that in many states where unemployment has reached some of the greatest heights, in many states where health disparities were already quite large, in many places where residents have higher levels of chronic diseases and other disparities, Medicaid expansion doesn't exist, making it so that the safety net is incomplete in those states. In those 12 states before COVID hit, 2 million people plus were uninsured, creating what we call a coverage gap. After COVID, early estimates are that as many as 20 million people could be caught in the COVID-19 downturn, losing employer-sponsored insurance and not being able to enroll in Medicaid because their state chose not to expand. As you can see, many of these states are in the Deep South. There's an overlay, of course, with the Confederacy, which means that many of these states have high proportions of Black and brown people, stark racial health disparities that existed already before COVID, stark economic disparities, often based on race, but also income, and of course, a history of slavery, Jim Crow laws, and segregation in medicine. We know that Medicaid expansion has measurably improved coverage, access to care, and also things like infant mortality for Black communities. In addition to who is eligible for Medicaid, there's also unique timing features. Medicaid has what we call open enrollment, meaning that you can enroll at any time. It has retroactive coverage for the 3 months before Medicaid you became eligible, and it has presumptive eligibility, which again, states can choose to allow people to enroll in the moment that they show up at a hospital. Medicaid has more comprehensive benefits than either Medicare or commercial insurance. It limits severely the out-of-pocket payments that are available. We also know that Medicaid makes it so that states cannot randomly disenroll their enrollees. In other words, anyone who's a Medicaid beneficiary is protected by the law to remain enrolled so long as they are legally eligible. These and other safeguards make it so that Medicaid has core features that protect the poor people who are enrolled in it. These rules and protections make Medicaid what we call an entitlement, but that entitlement doesn't just flow to the beneficiaries in Medicaid, it also flows to states. States receive uncapped federal money in exchange for abiding by federal rules, and that federal money is determined by what we call the Federal Medical Assistance Percentage, or FMAP. The FMAP ranges from no less than 50% of a state's expenditures to as much as 83% of a state's expenditures in Medicaid. So the easier way to think about that is for every Medicaid dollar, a state receives at least 50 cents from the federal government and as much as 83 cents from the federal government. The FMAP is based on the prior 3 years average of per capita income in a state, but is redetermined annually. This makes it so that poorer states always get more money from the federal government. In addition, Medicaid provides what we call countercyclical spending. In other words, when state budgets fail, like they are now during the COVID recession, the federal government steps in and helps them because the federal government can deficit spend. States have balanced budget amendments in their constitutions and therefore cannot deficit spend, making it so that they rely even more heavily on federal spending when an emergency strikes. During an emergency, the FMAP needs to be increased, as Sydney will talk about, because as we saw with the ARRA during the Great Recession of 2008 and 2009, states cannot just rely on that annual determination. They need immediate money. And so the ARRA created a 6.2 percentage point bump in the FMAP for states that lasted for a couple of years so that states could recover from the recession and help their residents. In terms of waivers, one key feature of expansion that has been controversial in this time period, really since 2017, is that the Trump administration has stretched the boundaries of waivers, making it so that states can make it more difficult for Medicaid expansion populations to enroll in Medicaid. The work requirements that have come with these waiver stretching maneuvers have been struck down by federal courts every time that they've been challenged in litigation. And in fact, none are in effect right now. Some are in the midst of litigation, but have been stayed while COVID is continuing. And this is important to note simply because there have been maneuvers in an attempt to undermine Medicaid expansion that make it so that Medicaid expansion is not functioning as well as it could in this moment because states have been allowed to undermine Medicaid by waivers through the Trump administration's approval. To be clear, this is not evidence-based policy. We know, as I said earlier, that the percentage of uninsured adults in states expanding Medicaid has improved, particularly for people with historic disparities. We know that over 400 studies show that expansion is effective in increasing insurance coverage, improving access to care, decreasing social determinants of health, and decreasing disparities in coverage and access to care. All of these things tell us that if non-expansion states decided to engage expansion, we would see an improvement quickly in terms of the problem of uninsurance in the US. I'll turn it over to Sydney now.
Thank you, Nicole. It's a pleasure to be here today and talking about Medicaid. As Nicole has explained, Medicaid has a unique safety net structure, and we need that safety net during public health emergencies, whether it's a tornado in Joplin, the hurricane that's hitting the Gulf Coast right now, or this COVID pandemic. Public health emergencies disrupt healthcare delivery, they wreak havoc on the community jobs and employer-sponsored insurance. We need Medicaid to be able to adapt quickly to the new and different demands on services during public health emergencies. And as Nicole has already explained, Medicaid gives states great flexibility. In addition to the flexibility that Nicole has already talked about, those state plan amendments, those waivers, once the Secretary declares a national emergency and the Secretary of HHS declares a public health emergency, those two orders together trigger authority for the Secretary of HHS to waive certain provisions of Medicaid under Section 1135 of the Social Security Act. You're probably going to hear a lot about Section 1135 during this series of webinars. It's an important authority for the Secretary during times of public health emergency. With Medicaid, it gives the Secretary authority to modify certain provisions in the Federal Medicaid Act at a state's request to assure that sufficient health services and providers are available during the emergency. 1135 has been used for decades to respond to hurricanes and fires, and now it's been adapted to respond to COVID-19. HHS very quickly updated its disaster response 1135 toolkit to pivot from a focus on natural disasters to a focus on pandemics, creating templates that states could use to request additional flexibility. And I can report that all 50 state Medicaid programs have used all of these flexibilities in various ways to pivot in an attempt to respond to the new and unique demands of COVID-19. A few examples, and only a very few of many examples. Removing prior authorization requirements for medication and treatment and institutional care. Expanding the use of telehealth. Reducing provider qualifications to assure that people who rely on home and community-based services paid by Medicaid could continue to get services during stay-at-home orders. And also adapting nursing home eligibility, reporting, quality, and safety metrics to try to respond to the unique needs of COVID-19. And in some cases, states have increased provider payments specifically to reflect the increased cost of personal protective equipment. However, the flip side of state flexibility is inconsistency across states. States are doing a lot of different things to respond to COVID-19. And I direct you to the Kaiser Family Foundation COVID-19 Emergency Medicaid Tracker, which will give you all of the variety and the details. What we don't know, though, is how well these various emergency response policies are protecting access and protecting continuity of care. We just don't know yet. What we do know, though, is that we need Medicaid to be available to enroll newly unemployed people so that they don't fall into the ranks of the uninsured. I want to address two particular stressors that are occurring during this COVID-19 time that have to do with Medicaid eligibility, Medicaid federalism, one of which Congress has already responded to. The other one needs a congressional response. And the first stress point, Nicole has already alluded to. It has to do with money. Medicaid federalism is based on generous financial support for Medicaid. States get that matching fund called the FMAP, and that allows them to provide Medicaid services. But during this economic downturn related to COVID-19, as in every economic downturn, state tax revenues go down, and states are greatly challenged to be able to come up with their state share of Medicaid financing. Just when we need Medicaid the most, it is at risk of state cuts because of state tax revenue drops. Congress has developed a response, but it needs congressional action. In the Families First Coronavirus Response Act, which I'm going to shorthand as the Families First Act, which was passed in March, Congress authorized a 6.2% increase in the federal share for most Medicaid services. And those are the services that some states get 50% federal match, others get as much as 83%. And so those get bumped up by 6.9%, or at least Congress offered that increase to states. Here's the second part of the congressional response, and it's a tried and true response. In return for enhanced federal money, states have to guarantee that during this public health emergency, they will not cut enrollment or eligibility. States have to agree that in return for this money, they won't cut Medicaid eligibility, won't impose more onerous enrollment procedures, won't charge higher premiums. They will not disenroll any person unless that person asks in writing, dies, moves out of state. And that's classic Medicaid federalism, an offer of generous financial support to states in return for some conditions put on that funding. Experts predict that this economic downturn, though, is going to be much worse than the Great Recession of 2009. And while Nicole mentioned that then Congress authorized a 6.2 increase in the federal MAP, that was a minimum amount. States who were harder hit during that economic downturn could get as much as a 12% increase in their federal matching funds. And many of us, including Nicole and I, are concerned that this is going to be a long and drawn out economic recession and that states are going to need more than a 6.2% increase. The National Governors Organization, 20 consumer organizations have appealed to Congress to increase that federal Medicaid match, to have it extend not during just the public health emergency, but until the economy turns around. And we hope that happens. At this point, all 50 states have accepted the offer of an increased FMAP. They have agreed to maintain eligibility and enrollment. There's also another condition that they cover COVID treatment and testing at no cost to the patient. I can also report that 43 states have eased eligibility rules even further at this point. Some have expanded eligibility, some have eliminated premiums altogether, others have streamlined application and enrollment processes. But as this COVID-19 emergency continues and the economy stays tough, it is going to be very difficult for states to go forward without additional help from Congress. And I want to move to my stress point number 2, and that has to do with Medicaid expansion. Because of Medicaid federalism, Medicaid eligibility and enrollment policies vary greatly across states, with the greatest difference possibly being that decision whether to expand Medicaid. And if you think back on that map that Nicole showed you, 12 states have yet to expand Medicaid. And if you think about the colors on that map, 8 of those 12 states are deep southern states. Those are states that have a high population of Black and brown people. They have severe health disparities, and they have severe economic and racial disparities. I'm going to add to some of the numbers that Nicole gave you. According to the Urban Institute, in states that have expanded Medicaid, about half of the people who become unemployed and lose their employer-sponsored insurance will be able to enroll in Medicaid. In non-expansion states, almost 50%, 40% are going to fall into the roles of the uninsured because there is no Medicaid expansion available. We need Medicaid coverage in a public health emergency. We need Medicaid coverage to address racial disparities and health inequities. Where a person lives and whether the state has expanded Medicaid should not determine whether they can get Medicaid coverage during this pandemic. We need to move the conversation about Medicaid expansion forward. And Nicole and I want to leave you with a couple of recommendations that relate to Medicaid expansion. One is we want to urge Congress to use Medicaid's cooperative federalism, as it did in the Families First Act, to offer states that have not expanded Medicaid 100% federal match for the first 3 years of Medicaid expansion. That is the offer that the Affordable Care Act gave to states that expanded in 2010 and 2011 and I think I got my dates mixed up there, 2014, 2015, and 2016. And it makes sense to do that now. We certainly can't guarantee that these states will take that offer, but it keeps the conversation alive. It keeps at the forefront the importance of Medicaid expansion. We would also encourage Congress, as it did in the Families First Act, to apply the 6.2% bump up, not just to most services, but to services also for people who are in the Medicaid expansion group. States that have expanded Medicaid are now getting a 90% match, and that is very generous. But these are going to be difficult times, and we don't want to see Medicaid's federalism standing in the way of Medicaid expansion. And with that, I think we will turn it over to have a little bit of time for some questions and answers.
So I see a question from Emily Kim. Some COVID flexibilities have allowed my clients' child Medicaid beneficiaries with disabilities to access care they needed before the pandemic began. Do you have thoughts on how seeing these flexibilities in action may affect Medicaid policy in the future? We anticipate that the end of the flexibilities will lead to a lot of demands from consumers for them to continue based on positive outcomes.
Emily, I'm not sure what state you're from, but I think at this point, what is really important is for us to be collecting the stories as well as the quantitative data about what is working and what is not. I think there are wonderful success stories. We're also worried that particularly some of the relaxation of provider qualifications may end up putting people at risk. So I think this is really an opportunity for some very important learning. For those of you in the audience who may be public health researchers, it's really a good time to be working with our communities and identifying both what works and what we can improve.
I would only add to that there has historically been occasionally the example where states exercise options, those options work, and then those options become mandatory features of Medicaid. So including pregnant women as a mandatory category of eligibility is an example of that, or women earning up to a certain amount of money anyway. So I agree with Sydney wholeheartedly that the more you can document the successes or failures of these flexibilities that you're witnessing, the better it will be going forward if you want to advocate for a more stable structure. Because the difficulty is that if it's an option and not a mandatory feature of Medicaid, then it makes it harder to ensure that if you move from state to state, you get the same kinds of benefits.
I think I might also want to add that the enhanced federal match only lasts during the public health emergency, and public health emergencies only last 90 days. So the declaration we're in now is due to expire at the end of October. If that public health emergency is not renewed, we're going to lose that additional flexibility, and states are also going to lose this enhanced FMAP. So one, renewing the public health emergency is important. If Congress could reach some agreements and extend the FMAP or connect it to economic factors rather than the public health order, that would provide, I think, some great relief for states and some certainty about how they can go about their budget planning.
So I see another question. Can either speaker address a little more from James Hodge? Thanks, James. Hello. Can either speaker address a little more on the long-term trajectory for greater use of telehealth services after the emergency declaration supporting some interventions have concluded? I'm sure it will be renewed, but what about 1 to 2 years from now? I think this is a really important question. I have heard that telehealth is a boon and also a challenge. And I think that we have to keep in mind that telehealth is merely a tool. It isn't a cure for what ails the American healthcare system. It is important for people who perhaps are stuck at home to be able to use telehealth in order to see their physician, so long as they don't actually need to be seen in person. But I worry a little bit that telehealth can leave behind people who don't have equal internet access. I worry a little bit that it can leave behind people who actually do need to see a physician in person rather than remotely, and that it could cut both ways. So I do think that what we see with this administration is that there's a desire to improve the use of telehealth and to pay for it, especially in Medicare, but Medicaid, I think, is following on. I think the question will be, again, can we document that having more access to telehealth is a game changer for people? I think the answer is yes, but evidence is always welcome. Sydney, what do you think?
I agree, and I think it's where we're going to need to drill down, and I think that's what the public health Law Network is very good at doing. I've just come out of meetings with people in my community who've been using telehealth with opioid medication-assisted treatment, and it has been a boom for them. And we will be working to document how effective it has been and some new ways of delivering care. So I think what we're going to have to do is some very drill down specific descriptions of, you know, exciting experiments that have worked that need to become business as usual, not emergency response.
I see another question. Interesting about the 12 states. Wyoming is one of them, and they had Jim Crow laws on the books until the late 1980s. It seems obvious Jim Crow states rejected Medicaid expansion. Getting 1115 waivers is almost impossible as CMS is not moving these along. So yes, there's a clear overlap. The 1115 waivers are moving. If you look at the whole world of 1115 waivers, they are moving along. So as Sydney was describing, there are a number of waivers that are being implemented in the context of the emergency. There were states trying to get 1115 waivers to do things like implement work requirements, to implement partial expansion of Medicaid under the ACA, which of course is not legally permissible. Neither of those things are. And those waivers have been approved. They've even been approved for states like South Carolina, which does not have Medicaid expansion and doesn't seem to want to expand Medicaid anytime soon. However, federal courts have stayed those waivers as a procedural matter, with the federal circuit court telling us that there's almost no way that these could be substantively legal either, because preventing people from enrolling in Medicaid doesn't seem to serve the purpose of ensuring that medical care is paid for poor people. So I'm not sure if that's what the question is getting to with 1115 waivers, but that's my immediate reaction. Sydney, what about you?
I think you covered it, and I think we're just about out of time on this subject. I do want to respond to a quick note that James Hodge wrote about, you know, what do we do 1 or 2 years out from here? And if that was in response to my comment about supporting states with an enhanced match, you tie it to the economic circumstances. I think there is also a permanent fix that would be a very welcome idea in Medicaid, and it's been floated for a while, that Congress authorize an automatic increase in the federal share for Medicaid during certain economic conditions, making it state specific. So if you have a hurricane devastate Texas, that there can be an adjustment in a way within the Medicaid financing system to provide extra support as that state recovers. That doesn't answer all the questions about additional flexibilities that are allowed under the 1335. But we could go on forever talking about Medicaid, because that's what Nicole and I love to do.
I see a quick response from James. What about telehealth mental health services? Those might be most useful in rural settings. I couldn't agree more. I actually think one of the really effective examples of use of telehealth, especially in this moment, but certainly going forward, is access to something that is more talking to your primary care physician so that they can diagnose you. Talking to your mental health specialist, right? I do think that there's a lot of potential there. And I would like to believe that CMS sees that as well. I think it's a little bit of a time will tell, but it's certain that there are some ways, at least, in which telehealth is improving access in rural areas. So I do hope that that will spill over into more normal times.
So I'm going to step back and turn it over to Nicole to begin our discussion of private insurance in this time of COVID-19.
So I am now putting on my Elizabeth Weeks hat. Again, this is her excellent chapter in our rapid response to COVID-19. Luckily, I often teach private insurance and again, write it with Elizabeth, so hopefully I can do it justice. I'm going to go ahead and share my screen again for just a moment so that we can get kind of the big picture of what, bear with me one moment, the big picture of what's available in terms of health insurance coverage. As you heard Sydney say and me say in the first half hour of our time together, one of the huge questions that's happening right now is what will happen with people who are losing jobs and losing insurance coverage. Some folks didn't have insurance coverage either because they were in the coverage gap or in Medicaid non-expansion states, or because maybe they couldn't afford insurance coverage. Or as Elizabeth points out, some people may have chosen not to purchase insurance. However, most people in the United States, a majority of people in the United States, still rely on commercial or private health insurance to access healthcare. The ACA enacted comprehensive reforms to extend health insurance to more than 20 million people who lacked health insurance when it was created a decade ago. And many of those people were stuck outside the system. It wasn't that they weren't choosing to have health insurance coverage through their employer, but rather that it wasn't offered or was unaffordable for them. And so many people viewed the ACA as a sort of fragile compromise because it wove from an already fragile fabric a scheme for near universal coverage, which is what you see here in the slide that I'm sharing. If you've seen me talk about this before, this slide probably feels familiar, right? We know that one part of that fabric was Medicaid expansion, which we've spent some time talking about already. But we also have a number of other pieces to the ACA that were designed to craft near universal coverage. And we say near universal because undocumented immigrants and some documented immigrants were excluded from this scheme. But setting that to the side for the moment, we know that the ACA was meant to create as near as possible, as could be achieved in the political circumstances of the day, universal coverage. COVID-19 casts in stark relief the weaknesses of the ACA's universal coverage design and its steady erosion since 2017 through legal challenges, through implementation hurdles, through executive orders, and to a degree through partisan politics. We have heavy reliance on employer-sponsored insurance coverage. We have limited public entitlements. We have a sort of wild west of individual and small group insurance that are frankly failing to serve public health needs. And even under normal circumstances, this was the case. But now with a global pandemic and a major economic recession, the weaknesses in the ACA's design are becoming even clearer. There are components that we need to talk about to understand what those weaknesses are. So they include employer-sponsored insurance coverage, individual and small group plans, the role of the exchanges, and also non-group plans. So I want to talk a little bit about each of these features of the ACA. Large employers offer employer-sponsored coverage to a great degree. The larger the employer, the more likely they are to offer employer-sponsored health insurance coverage. And the ACA made it so that those employers who are 50 plus must offer affordable minimum value coverage to employees. This means that coverage is affordable if coverage for the individual, not the family, costs no more than roughly 10% of household income. And coverage is minimum value if the plan pays on average at least 60% of the cost of covered services. If the employer fails to provide this coverage, then there were tax penalties implemented in the ACA. Small employers were not subjected to this, meaning anyone under 50, but they may be eligible for tax subsidies to help their employees purchase insurance through the exchanges, which I'll get to in just a moment. In addition to the behemoth of employer-sponsored coverage, we also have individual and small group plans. The ACA did a lot of work in these markets, which were really very small and ineffective before the ACA came into existence, and dramatically overhauled these markets. There are really two key reforms for understanding how individual and small group markets have been working post-ACA. The elimination of pre-existing condition exclusions was one of the key features of these reforms, which disallowed premium rate variation based on individual risk factors. And of course, there are some limited exceptions like age, geography, tobacco usage. But also, you would think that this makes it so that if people cannot be excluded for pre-existing conditions and premium rate variation is not permitted, i.e. community rating is required. You would think this means that if people lose their coverage from their employer, that they would still be able to gain coverage without price gouging, even after being diagnosed with COVID or something else, right? One would think that these reforms cover those who are losing insurance coverage. But it's a little bit more complicated than that, because there are also rules that come with using the exchanges. So what are the exchanges, or what we call marketplaces, because there's no Spanish language equivalent for exchange? The exchanges or marketplaces are sort of like Expedia, except for health insurance. They're a place where you can go buy health insurance, know what kind of product you're getting, right? So they make it so that private insurance markets are more accessible, because all insurers on the exchanges have to play by certain rules of the game. They have to operate in particular ways. And we have to understand too that all non-group plans have to do things like provide essential health benefits, right? So that people purchasing on the exchanges know what they're getting. There are two kinds of subsidies available in the exchanges. People can get premium tax credits to purchase private health insurance, depending on what they earn, from 100% to 400% of the federal poverty level. And also cost sharing reduction payments are available for people purchasing on the exchanges if they earn less than 250% of the federal poverty level. However, the exchanges and employer-sponsored insurance have annual open enrollment periods, meaning that enrollment occurs once a year, usually at the end of the year, for a limited time period, November, December. There are life event exceptions that make it so that if someone loses their coverage, if they move across state lines, if there's a death in the family, marriage, birth of a baby, adoption of a baby, etc., then this triggers what's called a special enrollment period. The special enrollment period gives a person 60 days from that event to enroll in new coverage. If the consumer misses the special enrollment period, then they have to wait until the next open enrollment period to apply. These rules do help insurers to predict their costs, which is helpful for market stability. But on the other hand, the effect of it is to prevent or to delay some people from accessing health insurance, even though we have rules that do things like prevent the use of pre-existing condition exclusions and that require community rating. So in the COVID-19 context, this means that individuals without qualifying life events who are seeking insurance outside of open enrollment are out of luck. There are many people who cannot enroll in private insurance until open enrollment occurs. Further, the havoc of losing a job makes it so that many people cannot be attentive to that 60-day window. It is unrealistic for a lot of people. Now, we do know that there are coverage requirements and out-of-pocket limit requirements that apply to employer-sponsored insurance, to individual and small group plans, and that those plans have to cover things like preventive care without co-payments. All of these are important features for purchasing commercial insurance. And there are also out-of-pocket limits that make it so that people who have commercial insurance are somewhat protected financially if they encounter severe medical risk. For 2020, the out-of-pocket limit is $8,150 for individual coverage and $16,300 for families. Most low-income families who are purchasing private insurance through an exchange cannot afford those limits, and many would call that an unpleasant surprise. States can impose additional coverage requirements. States can also protect insurance consumers in particular ways, but it is important to note that much of employer-sponsored coverage won't be reached by any state reforms because of the law called ERISA, which makes it so that any self-funded employer-sponsored coverage exists under federal law and generally cannot be touched by state law. So even if states are inclined to enact broader COVID-19 coverage protections, it won't reach a considerable number of insured individuals. One final point before I turn it over to Sydney. As of 2019, the individual mandate penalty was zeroed out under the Tax Cuts and Jobs Act. That meant that people could choose not to purchase health insurance under the ACA, and although the individual mandate is still part of the law, it has a $0 penalty. Because it has a $0 penalty, estimates are that probably about 1 million people haven't purchased insurance when they might have otherwise, because there's no penalty right now for purchasing insurance. Some of those people may have purchased other kinds of insurance that are not ACA compliant. So, for example, there are some plans that are merely catastrophic, which have very high deductibles and high cost sharing obligations. There are also short-term limited duration plans that do not meet the standards of the ACA, that don't cover essential health benefits. And those kinds of plans carry great surprises for those who enroll in them and get sick, because they often involve quite a lot of out-of-pocket spending, even once a person has obtained that insurance coverage. I'll turn it over to Sydney now.
Thank you. And I want to say how I think pleased both Nicole and I are to be able to step in for Elizabeth Weeks today. This is her work, and she's also a dear friend and a wonderful colleague to many of us. And we feel like we are honoring the job she has taken on as Associate Provost at the University of Georgia, where she is helping a major university figure out how to respond to this crisis. So we're very happy to present her work, and hope you will read it, the original work she did in the book. You know, Nicole has painted the private insurance landscape post-Affordable Care Act, which improved the situation, but it's clear from what Nicole has said, it's still patchy, it's still rough. It still has a lot of holes and a lot of warts in it. And the COVID-19 pandemic basically plays into a lot of those warts. I want to talk about 3 of them. One is enrolling in commercial insurance when you lose your job during this crisis. The other is commercial insurance coverage for COVID testing and treatments, particularly. And also what we're seeing in terms of consumers' exposure to out-of-pocket costs for COVID treatment, especially out-of-network costs. So let me start with enrolling first, because that's a question of just getting coverage. Nicole has set things up here by explaining that commercial insurance is very different from Medicaid. You can enroll in Medicaid at any time. With employer-sponsored coverage, with marketplace coverage, you have to enroll during the open enrollment period. And generally that occurs toward the end of the year, October, November, December. So as people were losing their jobs, losing their employer-sponsored health insurance, looking to the marketplace as an alternative source of commercial insurance, generally the enrollment period was closed. You would have to show that you qualified for a special enrollment period, which does include losing your job, losing your health insurance. But even that requires a lot of jumping through hoops. It's not an easy process. It is an administrative barrier, and that's one of the reasons we have navigators to help people through. 13 states responded to that challenge, and those are states that operate their own state-based health insurance exchanges, marketplaces. All but one of those states, all of them except Idaho, opened up their health insurance marketplaces so people who didn't have insurance could sign up for marketplace plans. And that included people who just didn't think they needed coverage before, or who had bought a catastrophic plan or a short-term plan that didn't provide very good coverage. And that's a very important policy solution. It is not the approach that the federal government took to the 38 states that rely on the federally facilitated marketplace. The Trump administration has refused to open it up, so people do have to go through proving that they qualify for a special enrollment period. And by and large, employer coverage is going to be closed until we get into the fall and the open enrollment period. The thing that Congress has not done at this point is to address COBRA. Because remember, COBRA is a way for employees who lose their employment and who had employer-sponsored insurance to continue that coverage. The requirement is they have to pay the full cost, both the employee's share and the employer's share, plus 2%. And that can be a financial barrier for many people. In 2019, the average premium in the employer-sponsored market for single coverage was $7,000. For family, that's $20,000. I think I will give Elizabeth's recommendations here rather than waiting till the end. She recommends that the federal marketplace should open up completely to allow people a chance to make informed decisions now that we are in a time of pandemic, that state marketplaces should remain open, that employers should consider opening up their enrollment, and maybe Congress should consider acting, since, as Nicole has mentioned, 60% of people with employer-sponsored coverage are in self-insured plans that only Congress can regulate. And finally, that Congress should do as it has done in other economic downturns to provide subsidies to help people purchase that COBRA coverage, especially helpful so that people can continue in the networks they've been in when they lose their coverage. So that's a coverage aspect of commercial insurance. The next thing I want to address is insurance coverage for testing. Nicole mentioned that under the Affordable Care Act, we now cover preventive services at no cost sharing to the patient. That has been a wonderful boom to preventive and primary care. However, a diagnostic test for COVID that you go in to get because you have symptoms and you're not sure what those are symptoms of doesn't count as preventive care. It's diagnostic care. So there normally is cost sharing. I will say this is something that Congress realized, and in the Families First Act and then in the CARES Act, they both addressed the issue. And now most insurers must cover COVID-19 testing with no cost sharing, no pre-approval, no pre-cert. That applies to group plans, individual plans. It doesn't cover those short-term plans, those catastrophic plans, those bare bone plans. And we continue to worry about people who bought those plans without knowing what they were not getting. This federal law covers both the testing for the active infection and antibodies. The coverage requirement lasts for the duration of the public health emergency. We see that time limit. And while it first only applied to FDA-approved tests, the CARES Act has broadened the coverage to include tests used by state-developed labs, by clinical labs on an emergency basis, and even by manufacturers who say they are seeking FDA approval but don't have it. And the no-cost provision applies to services and items provided during a medical visit that results in the testing. So what that means is if you go in and first they do a flu test, that's going to be covered under this broader definition. If later on in that visit they decide it's not flu, let's test for COVID-19. It will be a package of services. All good news. We got a couple of issues though, because there's always the unintended consequences. The language in the federal legislation says it's covered testing when it is medically appropriate as determined by a treating physician in accordance with accepted standards of current medical practice. Here's the problem. We have people going in for tests because they think they have been exposed, not because they have symptoms yet. We know that is really important for understanding the spread of the disease, for stopping the spread of the disease. That's a problem. The other problem we're having is we are seeing some self-funded large employers arguing that the provisions of these federal laws don't apply to them. Elizabeth thinks that's incorrect. Many experts think that's incorrect, but there's a little bit of ambiguity there. So Elizabeth is making a couple of recommendations. One is that this coverage of COVID testing at no cost to the patient should apply not just when recommended by a medical professional, but when recommended by public health authorities, so that we have good public health as well as good medicine here, and that the language be clarified so there's no question that self-funded plans are in fact covered. The final issue is coverage for COVID-19 treatment. We've all read the news reports of people being hit by extraordinarily large bills. And this is something that's not addressed by either the Families First Act or the CARES Act. And my advice as a lawyer would be read your plan. Figure out what your cost sharing is, what your out-of-pocket limits are, and as Nicole has said, they can be high. The COVID-19 issue we've seen is what has become a perennial issue of surprise billing. People who go to a hospital knowing that the hospital is in their network, and then it turns out that the emergency room physician who sees them or some other provider or the lab that's being used is not in their network, and they are being hit by extraordinarily high bills. This is an ongoing problem. It was a problem before COVID. It's a problem now. It's a problem that needs a congressional response, again, because so many people are covered by self-insured plans. I'm going to wrap it up there and turn it over to Nicole, who's going to talk maybe about some other responses, or we may see what she does at this point.
So I'm not seeing any questions. If anybody has questions, you're welcome to share them. But since we have a couple of minutes and no questions in the queue right now, I'll just mention that Elizabeth put forth a couple of suggestions that Sydney didn't touch on that, that could address some of the issues we've talked about. So for example, if states enact their own individual mandates, then that makes it so that people may be more inspired to buy health insurance, even though the federal individual mandate is zeroed out. We could have a whole other session talking about what might happen in the litigation of Texas versus California, i.e. the next big challenge to the Affordable Care Act. Of course, the case holds no real legal water, but all of our presentation, probably needless to say, hinges upon the assumption that the ACA continues to exist. I really don't think that repeal is in play at this point, given the failures of 2017. However, that litigation is looming over us in November. And that's my commentary, not Elizabeth's. But her last point is that states could try to create their own public options. Now, again, this limits us to a state-based approach, but it does make it so that states have some impact on the increasing roles of the uninsured. And with 20 million people potentially losing health insurance, that really could make a big dent depending on where the public option might be enacted. Any questions for us regarding either Medicaid or private insurance or related topics?
And maybe while we're waiting on that, this is, the large issue here is the difficulty of relying on employer-sponsored health insurance. Because when you lose your job, you lose that health insurance. And certainly that fault line in our insurance coverage system has come to highlight, and we've had a really harsh light shown on it by COVID. And I think it will be interesting going forward to see what kind of larger solution debates we see bubbling up.
Mostly what I think we're seeing is a lot more slicing and dicing, right? A lot more filling in the patches. And the problem is with employer-sponsored insurance that it basically is the haves versus the have-nots. The problem with state-based solutions is it divides us again into haves and have-nots to a degree, because wealthier state governments are better able to come up with these kinds of policy solutions. It also leaves people who are not as able to engage politically or civically at the whims of their governments, which may be stingier in terms of social programming, so that we have another feature of this, which we heard about earlier, the political determinants of health, which absolutely plays into the kinds of health reform that we come up with going forward. So
we have a question in the Zoom chat, is there also a pre-existing waiting period going from employer-sponsored health insurance to exchange insurance?
There is not.
But realize you can't just decide you want to switch in the middle of the year.
Correct. You have to
ha-
play by the rules of open enrollment and or have a special enrollment period. So that would be the waiting period that could apply. Well, thanks so much, everybody.
I think we did perfect on time. Thank you for all the great questions
It's
and
a
comments.
miracle. And thanks so much to our hosts and everybody who's put so much hard work into putting the Public Health Law Summit together. It really has been a privilege to participate in it. Thank you.
And
I
thank
would
you,
like to
Kayleen,
thank
for all
our-
your help today.
Yes, I would like to thank our incredible presenters for a great session. We would encourage you to press the button underneath the video feed and tell us what you thought of this session. Thank you for attending and have a great rest of your day.
Take care, everybody. Thank you.
Bye.